Oh, okay, fantastic. So thank you so much for the invitation to participate in this truly important process. And so in our pre-meeting conversations, we determined that the following topics would be of interest to the audience. And so I'm going to spend a few minutes on each of these topics. So I am an orthopedic surgeon, and surgery is physical and it's mechanical. And we do the best when there are structural issues that we can correct with surgery, and those structural issues lead to the pain, dysfunction, and disease that we're treating. In orthopedic surgery, I'm used to patients being very, very grateful after their joint replacement. And we use this procedure to restore joints that are completely damaged. And it has become one of our most successful procedures. I certainly gathered from the heartfelt discussions, and thank you to the patients for sharing their experiences, that this does not seem to be the case right now with replacement of the TMJ. In speaking to some maxillofacial surgeons, I come to understand the facial nerve is extremely close to this area, and also that the dural space is also just behind some of the implants. And so the joints that we commonly replace are typically much larger, and thus we do have a little bit more room to work with. And so here's a total hip, and the articulation is metal and plastic. Now, just to put something in perspective, it actually took us more than 100 years to get to this point. And Sir John Charnley, who is considered the father of modern joint replacement, nearly stopped his work following catastrophic failures with use of Teflon as the articulating surface. And so he did 100, and they did great over the first year, but by the second year, there were many, many failures, as that material just did not stand up to the mechanical forces of the hip. And fortunately for the field, his assistant convinced him to try one more time with high molecular weight polyethylene, and that has been the metal and plastic replacements that have been so successful for us. Now, having said that, we continue to have issues with bone fixation, infection, and in particular, mechanical failure. So material properties, implant design, surgical technique all impact on this, but so does wear debris and the biological reaction to the wear debris, which contributes to bone loss and oftentimes severe tissue reaction in some patients. Now, up until about the year 2000, so the turn of the last century, most of our joint replacement patients were over the age of 65 and treated for severe arthritis, complete loss of the cartilage, and severe bone deformities. These issues are, of course, of greater concern for younger patients, and it is my understanding that those facing TMG replacement are often very young. And because we do continue to have these issues, we have a long history with joint replacement registries. These were put in place to evaluate the clinical outcomes and implant performance. And you'll see that in many countries, they've been in place for several decades. Now, in the United States, and just before I move on to our American joint replacement surgery, the registry data has proven time and again to be very important in providing early warning of implants that maybe do not perform as well as those that we already have in the system. And one of the more recent issues occurred surrounding the use of metal and metal replacement. And it was registry data that quickly showed there were more early failures, and this led to appropriate alerts and also allowed registered patients to be contacted for increased postoperative and enhanced surveillance. And so in our country, we don't have a national healthcare system. Participation is voluntary. However, due to partnership with our key professional society, the American Academy of Orthopedic Surgeons, we are now tracking more than 1.5 million joint replacements performed in all 50 states, and enrollment continues to increase. Now, early on, one of the strategies that people looked into was biological resurfacing. Can we regenerate joints so that we don't have to go to metal and plastic? Because it isn't only elderly patients who are affected by painful and debilitating arthritis, trauma, cartilage tissue loss. And so the field of cartilage tissue engineering began almost 30 years ago when Chuck Baconte seeded chondrocytes onto biodegradable scaffolds. And he was able to show that you could pretty much create cartilaginous shapes of any type based on the shape of the scaffold. And so his ear mouse became quite famous in the 90s. You can see that this particular mouse had was growing cartilage in the shape of the ear in its back. And that certainly leads to cartoons like this. Now, I was one of the early investigators in cartilage tissue engineering, and my interest was in repairing and restoring joints. And so similarly, we were able to show that you can seed stem cells or mesenchymal stem cells into biodegradable scaffolds shaped like bone and cartilage, and that bone would form in the correct places as well as cartilage when they were implanted into the joint. And again, the geometry and the architecture of the scaffold pretty closely determined, in many instances, the shape of the resulting tissues. And moving forward, research, this particular one is from a colleague of mine at WashU, who has recently shown that you can create cartilaginous shapes that are of similar size to that of human hips. And in this particular case, he used adipose-derived stem cells and cultured them for 38 days to create this beautiful-looking cartilage. And so we've continued to progress. There's a lot of work in stem cells. Some of the more exciting work is with induced pluripotent stem cells. And this is just one example of where you can take adult human skin cells and reprogram them to an embryonic stem cell state. And in this example, we showed that we could redifferentiate those cells that were from an older adult into very youthful, young cartilage cells that had much higher regenerative capacity. And so when you couple this work with a more recent introduction of 3D printing techniques that allow you to print living cells and intersperse them within bioactive and biological scaffolds, you can pretty much create any shape that you want, and tissues that from the University of Twente, it looks like a small bone, and they're showing that there are living cells in there. And also pertinent to this discussion, the University of Nottingham 3D printed a jaw complete with forms for teeth. And so people often say, this is wonderful, can you implant this? And right now, these are experimental in laboratories only. Really the proving safety, efficacy, and being able to scale up these new technologies take up a tremendous amount of time and money that very few research groups are resourced or have the expertise to complete. And thus, even for the ears that were grown about 20 years ago at the 20-year anniversary, that particular technology had not yet achieved FDA approval. And so patients want new treatments, and there are some treatments that actually fall into a gray area where FDA regulation may not be needed. And this allowance traditionally permitted surgeons to perform treatments such as taking bone from one part of the body to help another bone heal or to provide structural support in an area damaged by trauma. In recent years, blood from so autologous blood and autologous tissues, so bone marrow, fat, other tissues obtained from the patient being treated have now been used to treat a variety of ailments that have been widely interpreted to fall outside FDA regulation. And this has led to what has now been called biologics or orthobiologics. And the use of these orthobiologics has largely fallen outside of clinical trials, and there's few supporting clinical data. The indications that do have some data showing in some patients improvement in symptoms are in knee osteoarthritis and in tennis elbow. Unfortunately, unproven treatments are actually falling in this category, being marketed as stem cell therapies across the country. And while these clinics are typically not run by orthopedic surgeons, the top 3 conditions treated are orthopedic problems. And so about a year ago, to address some of the increasing concerns, the American Academy of Orthopedic Surgeons convened a think tank meeting in collaboration with NIAMS at Stanford to work on improving the research in this space. And our goals were to establish a clear collective impact agenda for the clinical evaluation and use of biologics in orthopedics, and to also provide a guidance document on improving evidence-based practice in this area. And one of the key areas that we discussed was, what is the definition of a stem cell? So this term is being used broadly, and I think patients are correct when they hear stem cells to think that these cells have remarkable regenerative capacity, and that they have the ability to give rise to many specialized cell types and to regenerate bone, to regenerate cartilage, to regenerate tissues. That is, in fact, part of the definition of stem cell. However, the central issue in the current clinical use of biologics in this country is that most of what is offered are minimally manipulated cell preparations. There are no standards. These products are uncharacterized, and the studies that have been done show that these formulations contain very few putative stem cells. And really, it's about 0.01 to 0.001% of the cells in these preparations might be stem cells. And this is simply not enough to attribute any treatment effect from these preparations to stem cells. And thus, our work group felt strongly that these preparations should not be referred to as stem cell therapies. Rather, we suggested that they be referred to as cell therapy, and that where appropriate, the untested and uncharacterized nature of these treatments be clearly communicated within our profession to patients and to the public. And some other areas of discussion were also how to facilitate the bench-to-bedside translation of promising new treatments that have been well studied, and to establish guidelines that will allow a more accelerated approval process. As part of this effort, we are now working on leveraging our expertise with registries to establishing biologics registries that will help facilitate post-market assessment of the clinical effectiveness and also clinical outcomes of these treatments, and can provide us early warning where necessary if some treatments may prove harmful or not effective. And so my slide isn't quite advancing. We have published our recommendations. It is available by open access at the Journal of American Academy of Orthopedic Surgery. This really is the current status of biologics, and I'd like to thank you for your attention.